Now, I appreciate there's a lot on this board, and we're going to go over this really quick. We're going to go through a simple case, right? And then we're going to go through the options for that case. And then we're going to get a bit more granular into the reimbursement and kind of how most practices are functioning and how some practices might make a change. We've got a patient that walks in the door, and that patient has a history of, according to their primary doctor, plantar fasciitis. Now, most of you, if you're a podiatrist, you're seeing patients that have come from a primary doctor, come from a pain doctor, come from somebody else. They've almost always had some measure of conservative treatment. They've had steroid shots that were probably not done correctly, but they've had steroid shots. They've had some physical therapy. Maybe they had some acupuncture. Maybe they had shock wave therapy if that doctor had shock wave. They could have had acupressure. Maybe they even had prolotherapy. Maybe they were sent to a pain doctor and got prolotherapy. But by and large, they're sitting in your office and you evaluate them and you don't see any element of inflammation. And maybe you do an ultrasound and you're like, actually I have plantar fasciosis. No wonder it didn't get a whole lot better. And you really have three options as far as care from an interventional standpoint. And that's really what we're going to address here is interventional standpoint. You could give them more steroids. You could do PRP, PRF, PRM, or you could consider an allogenic allograft like Wharton's jelly. The merits we've discussed a little bit, right? But let's get just a slight bit deeper into how we would make those decisions. We've already talked about the fact that PRP necessarily can cause inflammation, number one. Number two, you're really only replacing that cartilage-based defect with just fibrin, which is type 1 collagen, which is kind of a third of what the body needs to heal itself. There was a great article published by Dr. Ashim Gupta. It was published in 2022, and we will reference it to this video. And in that study, Dr. Gupta, and this was actually a canine literature that he was referencing as well, they used PRP. And it was an in vivo, in vitro, where they looked at what happens when you put PRP with any red blood cells into a joint. And what they find is that the red blood cell dies in 3 days. And after 3 days, there's a cyclooxygenase pathway that happens with tremendous inflammation. And 2 days after that red blood cell dies, due to calcium aspartate, glutamate, calcitonin G-related peptide, you get predictable and inevitable cell death of chondrocytes and synoviocytes. And their suggestion was that if you're using any PRP, PRF, PRM, and there are any red blood cells, those red blood cells may actually accelerate degeneration of the joint as opposed to help. Now, there are no red blood cell free PRP kits, and every PRF and PRM still has red blood cells in it, all right? Well, the fact that doing PRP with red blood cells might accelerate degeneration of the joint, we've heard that before. Where have we heard that? Oh yeah, we heard that about steroids in 2022, radiology, publication demonstrating that steroids actually could have catastrophic effects, lead to osteonecrosis, other things, and that long-term repeat application of steroids can actually accelerate degeneration of the joint, doesn't improve cartilage-based defects, and this was in knees, all right? What about our allografts sitting over here? Well, what about our Wharton's jelly? It's type 1 collagen, type 3 collagen, hyaluronic acid. It's the identical building blocks to that cartilage-based defect that we're hoping the body will repair. That's an immune-privileged tissue. Wharton's jelly is immune privileged, meaning that there are no Rh antigens, so you're not going to have a graft-versus-host disease. The COVID vaccine spike protein doesn't cross the placental barrier, right? And there's not going to be an inflammatory response because it's immune privileged. Well, what happens if you put PRP in, say, the subtalar joint of the ankle? Has the synovial joint of your ankle ever seen blood in its normal state, not pathologic? Well, no. So if you put blood or PRF or PRM in the ankle joint itself, what happens? you're going to get inflammation. The body sees all that blood as a foreign body. And again, it's not necessarily blood, it's platelets and, fibrin, and irrespective, the body still sees it as a foreign body, and it responds by causing a bunch of inflammation. That's why usually after you do a PRP injection, number one, it's painful because it's inflammatory. Number two, they call you 24, 48 hours later and say, my ankle's swollen, really swollen. And you say, oh, it's all right, it's pro-inflammatory. It will get better. According to Dr. Gupta, maybe not. Aside from the science, let's talk about the economics of these scenarios. Okay, we know what the economics on steroids are, right? J-codes are no longer reimbursed. Dexamethasone's getting more expensive. Depomedrol's more expensive. There's a national shortage at times of normal saline. So all of the things that you used to get paid on for J-codes, you can't get paid on anymore. So 20610 reimburses about $65.60. Ultrasound, if you're using it, reimburses about $60. It's actually about $59.25 or 24. That's if you're using musculoskeletal ultrasound, and on your contract that musculoskeletal ultrasound actually pays, because sometimes it doesn't. You submit the code and it doesn't get paid. So the most you could hope to make is $120, right? Well, let's take that $120 and then let's carve that up, because almost every podiatric office runs about 60% overhead, right? And then you're paying between 7 and 13% for billing, and then you're paying about 5% for your EHR, right? Well, that $120 is probably more like 80. And that's if you're getting the musculoskeletal ultrasound component. Let's go over to your PRP, PRF, PRM. Well, again, we look to make about the same $120, right? We still have all the office overhead. So if we did ultrasound, we're still making conservatively, half of this. I'm sorry, 60% overhead on 120. We're not making anything. We're making like $40, $45. So maybe we're making $45 on that $120 bill. That's even if it gets paid. Well, our PRP kits cost between $150 and $320. Right? Arthrex is $320 for a PRP kit, and you got to buy them in a lot of 10. So you're writing a check for $3,200. Now, that's not it for the overhead, right? Because you got to hire a nurse or a venipuncturist to just draw the blood and spin it down. We also have time. You got 15, 30 minutes to spend spinning that blood down. And what nobody talks about with PRP are the adverse events. And I'm not talking about adverse events to the patient. I'm talking about adverse events to you, the practitioner. Because if you do enough PRP, eventually your nurse or your venipuncturist is going to get a needle stick. And then the bills start. Because they're definitely taking time off because they got a needle stick, right? They're definitely going to claim workman's comp because they got a needle stick. And unfortunately, they're probably going to sue you. So is PRP risk-free? I would suggest absolutely not. I know a colleague who's getting $1 million lawsuit from a certified venipuncturist who needle stuck herself and then blamed it on the doctor, and she sued him civilly. Not even malpractice, civil suit, because she just didn't like him. What about Wharton's jelly? Your cost on Wharton's jelly is $150. That's all the cost is, right? There's no venipuncturist involved. There's no possibility of a needle stick unless you, the doctor, stick yourself in the process of trying to do the procedure, all right? But you're not going to have an allied health professional or a nurse or a venipuncturist have an adverse event because there are no blood products involved, all right? Now, when you look at all of this and you look at the finance of this, I want you to process something simple and elementary. Your net for your insurance-based billing, whether you're doing steroids or PRP or Wharton's jelly, all right, is going to be about $45. That's about all you're going to get at the end of the day for that steroid shot or that PRP or that allograft, because this is what you're going to bill the insurance. Now, if your patient comes in and they have hyaluronic acid that they want injected, they're going to have to go out and pay for that hyaluronic acid. You write a script and they pay for the copay. And the copay for HA is on $400 or $500. So what if we just had a subtle shift? And we still build insurance for our allogenic allograft, but we had the patient pay for the biologic. Your net on this procedure, having done steroids, is about $45. All right? If you had them pay $300 for that biologic, which would be the cheapest injection anywhere in your whole state, because most people, just for PRP, are charging onwards of about $750 to $1,500. Say you just charged $300. You would net $150. And so for every single injection you did, where on the insurance side, you're netting $45, right? By just charging cash for your Wharton's jelly, just doubling the fee, not $750, not $1,500, just charging $300, you're netting immediately the amount that you're making off 3 patients getting these injections through insurance. Now, the math is pretty simple, right? Say the most podiatrists do onwards of 20 injections a week. That's a conservative number, right? So if we just take 20 times 150, right? And if they do that every week times 4, we can do the math on that pretty easy, right? Times 4, $12,000 covers a bunch of overhead, doesn't it? You didn't wallet check your patient. You charged them double the cost of the biologic. But on 20 patients a week, which is very conservative because most podiatrists see 30 patients a day, right? That's 4 injections a day with a net of $150 just on the injection. We're not even talking about insurance reimbursement for these patients. Just doubling the fee of the Wharton's jelly. You're looking at conservatively $12,000 a month cash. Hopefully this opens some eyes and engages a bit of conversation with you and your office manager. Because that $12,000 a month changes the entire practice dynamic for you. This could cover half, if not all, of your overhead. It could cover the salary of another podiatrist to join your practice and double the amount of patients you can care for, right? That type of revenue takes you on vacation to Hawaii or, upstate Oregon or heli-skiing in Whistler pretty simply. But that's how simple it is to use a very appropriate allogenic allograft for a very appropriate cartilage-based defect, right? And in a pretty honest way. You're not wallet checking the patient, you're charging them $300 for an application of biologics that everyone else in the country charges between $750 and $1,500 for. Most integrated chiropractors would charge $5,000 to $7,000 for that application. And their PAs or nurse practitioners are doing it. You are surgeons. This is not a lot to ask, but what a crazy amount you could gain by simply implementing a biologic in your standard algorithm for the most common things that you're seeing in your office every single day.